Hello, everyone. If I'm going to start now, this presentation is regarding this article that was written now in 2025. Bladder irrigation with the tap water to reduce antibiotic use for urinary tract infection in catheter users. Is everybody can hear me okay?
I think so.
Okay, thank you. Do you want me to wait or?
No, I think you're good to go.
Okay. So in human, catheter-associated bacterial cystitis are the most common healthcare-associated infection, and results in significant patient morbidity, healthcare cost, and occasionally mortality. So UTI are common complication among patients that they perform the clean intermittent catheterization, or CIC, and in the Welling catheter, IDC. In fact, annually UTI incidence rate for the CIC is 45%, and the annually UTI incidence rate for the IDC is 57%. So based on the summary, the guidelines of 2024 of the European Association of Urology infection, we see that the UTIs in patients with urinary catheter should be treated with antibiotics. But they also mention that the treatment of asymptomatic bacteriuria has no benefit in patients with urinary catheters. In this study, so when in this guideline, they consider asymptomatic bacteriuria if the only symptoms is cloudy or foul-smelling urine without any other symptoms of UTI. This was a study where they see that there is more pathogens that the causing catheter-associated UTI are more resistant to empirical antibiotics than non-catheter-associated UTI. So this make as to is very important, the need of urine culture before they start any therapy, antibiotic therapy, and also the importance of considering therapeutic alternatives. In veterinary medicine, we have this guideline that were written by the International Society for Companion Animal Infection Disease, and the guideline for the diagnosis and management of bacteria urinary tract infection in dogs and cats. So in this guideline, we call subclinical bacteriuria instead of asymptomatic bacteriuria. And in those guidelines, the subclinical bacteriuria is defined as the presence of bacteria in urine as determined by positive bacterial culture from a properly collected urine specimen in the absence of clinical evidence of infection urinary tract disease. So basically, if we found this bacteria, doesn't mean that in the urine, doesn't mean that we have an urinary tract infection, because we have to have the clinical evidence for that. Subclinical bacteriuria is not uncommon, and there are also predisposition factors for that. The rates of normally subclinical bacteriuria without predisposition factors are around 2 and 12% in healthy dogs, and around 1 and 13% in healthy cats. Then this percentage go higher when we have underlying disease like diabetes mellitus, obese, puppy with the parvovirus, dogs that they cannot, move with acute disc herniation, paralyzed dog, and also dogs that are treated with the cyclosporin or other immunosuppressive medication and glucocorticoid. So the big question that we have all the time is a UTI or asymptomatic bacteriuria? I think this one is a very big question that we ask most of the time. And they also in human, they have the same problem. Sometimes it's very difficult to differentiate between these two. And unfortunately, treating the symptomatic bacteriuria is what most cause this antibiotic resistance. In fact, identify clinical signs of cystitis can be very challenging in some of our patients, most if they have paresis, and also if the owner are not complaining, they are unobservant, they don't look when they go to urinate. But this one, sometimes we say human are easier for human, but it's not really true because they have a situation that are very similar. For example, paralyzed individual or individual with dementia. So also they have the same problem. In this population, for example, they change over an abnormal odor or a pyuria is not indication to treat. So it's not indication UTI and to treat. So when we have the antibiotic resistance, we have a very limited treatment option. And for this reason, all these studies are there because they are trying to explore alternative treatments for UTIs. So let's go back to the study now. Basically, the blood irrigation with the tap water has been proposed as a potential safe, efficient, cost-effective alternative for preventing and treating UTIs in patients performing CIC or IDC. Before this, the study that I'm presenting was another original study in 2023. It was a cross-sectional study that reported a good satisfaction and the subject improvement outcome in patients performing blood irrigation with the tap water. And this one is the study that you can see here. So prospectively, the study that we are now looking at is a prospective study, different from the previous study that was a retrospective study. So in this prospective study, we was evaluating the safety, the effectiveness of bladder irrigation with the tap water to reduce the antibiotic use for UTI in this patient performing CIC and IDC. And they were looking at the number of antibiotic treatments for UTI, the UTI incidence, and the UTI-related hospitalization. Also was evaluated the quality of life and the treatment satisfaction of bladder irrigation with the tap water. The outcome were measured with two validated questionnaires at the 2 time points. It was the baseline questionnaire that was retrospective because this one was done, was evaluating 3 months period before the initiation of the bladder irrigation. And then there was the follow-up prospective questionnaire that evaluated 3 months period after the blood irrigation initiation. What their hypothesis was that the blood irrigation with the tap water would reduce the antibiotic use for UTI without increasing the risk of UTI with the systemic symptoms. They also expected to have a high treatment satisfaction and improve generic quality of life. So the study design was a single-center prospective observational study, was performed between 2022 and 2024. and was done at the Department of Urology in the Erasmus Medical Center, Rotterdam, in Netherlands. So the uncomplicated UTI was defined as an acute onset of cloudy or foul-smelling urine and hematuria or dysuria, pain during catheterization, suprapubic pain, urinary incontinence, frequency, and urgency. If only the cloudy and foul-smelling urine was present, that was not recorded as a UTI, like I said before. The urine test was not a requirement. For urine test, is a urine culture, sediment, or deep slide. So it was not a requirement for this study. And the patient could start immediately the bladder irrigation upon recognition of the onset of symptoms for UTI. So when the patient was feeling the first symptom of UTI, could start the bladder irrigation immediately without doing anything else. The urine test was performed only if the antibiotics were needed. So before enter the study, this patient that has this recurrent UTI, they were first assessed to see if the treatment that they were on should be optimized. For example, neurogenic low urinary tract dysfunction, adding some medication, or if they were bladder stone, they were excluded via ultrasonography. And also they were offered behavior modification strategies. If all of these was not present, and then the recurrent UTI persisted, and then the blood irrigation with the tap water was initiated. The study population was a patient that has age more than 18 years old, performing the CIC or had a transurethral or suprapubic IDC. They started the bladder irrigation with the tap water due to the recurrent UTI. And for recurrent UTI, they intended 2 or more UTI episodes in the last 6 months. And then they have to complete the baseline questionnaire within a week after receiving the bladder irrigation instruction, and the follow-up questionnaire after 3 months. Other non-antibiotic treatment could not be initiated at the same time of this study. For example, cranberry use, dimanose, metamine, phytotherapy, intravesical glycosaminoglycane. So all of these should not be performed during the study. How the bladder irrigation procedure was done. So they were using a catheter tip syringe, and normally was a 50 ml syringe. They fill it with tap water at body temperature from a clean, non-sterile container. The bladder was actually irrigated by flushing in and out. And for sure, that was repeated until the solution was clear. They had to do a tapering schedule, and the tapering schedule was when they were seeing that the effluent that was coming out from the syringe was clear. So they were starting daily the first week, and then there was a gradual reduction every other day, twice a week, and once a week for this 3 months period. The data collection was performed by these 2 questionnaires, and there was a self-developed and validated questionnaires. And like I said, was a baseline questionnaire, and then after 3 months questionnaire. And they have to self-report the antibiotic treatment for UTI, the number of episodes with UTI, and then also the differentiating between the UTI with or without systemic symptoms. Also, they have to report hospitalization that results from a UTI, the quality of life based on the 5-dimension 5 level, and the treatment satisfaction based on the 9 items treatment satisfaction questionnaire for medication. So you can see here a little diagram where you see the starting of the bladder irrigation. And then we have a 3 months before, period before the bladder irrigation. They have to fill this retrospective questionnaire, and then a 3 months period prospective, so like after the bladder irrigation. And the first questionnaire, like I said, and I'm going to repeat it, is they have to answer the number of antibiotic treatment for UTI, the number of UTI episodes, the number of UTI-related hospitalization, and the quality of life. In the prospective one, they have to answer the same question plus the treatment satisfaction question. The statistic analysis was done by negative binomial regression. This is a type of a generalized linear model used to count data that are over-dispersed. To determine the appropriate sample size, they used the mean number of antibiotic uses from a previous study with an expected 30% reduction after starting the bladder irrigation with tap water. After adding baseline data from the first 30 patients and using a poison rates formula, they found out that at least they need 58 patients to have an 8% of power level, a 2.5% one-size significance level. So the patient selection was the patient eligible to the study were 82. They only 79 complete the questionnaire, and the baseline questionnaire was completed by 67, and only 7 patients did not complete it. So at the end, we had only 60 of these patients that they completed the follow-up questionnaire. So of this patient, we have some patients that discontinuing the bladder irrigation during the 3 months, and 13 of them. And the reason were kind of sporadic, but resolution of UTI symptoms, and that was good. Start an alternative treatment, the bladder irrigation discomfort and pain, no improvement in the UTI symptoms. And then for them, it was impossible to do the bladder irrigation. We see that the majority of them performed the bladder irrigation daily, despite they told not to do only for 1 week and then continue the tapering time for the bladder irrigation. The bladder irrigation duration was about the majority for 0 to 15 minutes. And the administration, the majority was performed by patient. If we see the patient characteristic, we see that the majority were male. They had the majority has a spinal cord injury, and the majority has the CIC catheter type. Now, if we look at the antibiotic treatment for UTI, we can see that the baseline 50 people as the antibiotic treatment for UTI, and the follow-up only 32 use antibiotics. For the UTI episodes, were like 58 people are baseline and 50 people are follow-up. So if we compare the baseline and after 3 months, we have that the number of self-reported antibiotic treatments for UTI was 38% reduction. And the number of episodes with UTI-related complaints was 38% reduction. The differentiating between cases with or without systemic symptoms was not different. So if we see here instead the treatment satisfaction, we can see the different portions. So the treatment or prevention, symptoms relief, speed of action, and you can see the majority, they were satisfied, around 37%. Easy to use, easy for planning, easy for using as instructor. All of these was also easy, so they were satisfied. The majority didn't have any problem. And then the confidence in treatment, confidence in advantage of treatment, global satisfaction. Again, the majority, around 40%, they were satisfied. If we compare the baseline after 3 months from this treatment satisfaction questionnaire, we see that only 58 of the 60 patients completed, and they found that the positive view towards subjective effectiveness, easy to use, and overall satisfaction. Different from the comparison baseline after 3 months for the quality of life, that they didn't find a significant difference. So as a result, we can say that the discontinuation was around 22% of patients discontinued the treatment. Like I mentioned before, the majority was due to the resolution of the UTI symptoms, and 7% due to the lack of efficacy or the pain and discomfort during the procedure, the bladder irrigation. The bladder irrigation with tap water make the patient to manage, allow the patient to manage the UTI symptoms independently without waiting. And all of these main conclusions were based on the patient-reported data. So there was some risk of inaccuracy response to a different interpretation of the survey, but they tried to do as objective as possible because the questions were the same in the baseline and in the post-procedure questionnaire. And then there were also some examples of this question and how to answer. So the introduction of bladder irrigation with the tap water in this patient with recurrent UTI results in a significant reduction of 38%, like I said, of antibiotic use, and 38% in the incidence rate of UTI. It was very well tolerated, easy to use. So there was based on the TSQM-9, was a global satisfaction with the treatment. But despite all of these, again, the quality of life didn't change. They suspect that the possible require longer time to have some improvement in the quality of life. So in the discussion, they talk about, in Netherlands, the tap water is a very high quality, is continuously monitored for microbiological agents. For sure, this doesn't happen in all countries. In some countries, this tap water is not the high quality, but they suggest that it can be replaced with bottled water or boiled water. The long-term risk associated with the use of this tap water is not studied yet. So we don't know if this one can cause a problem if we use it for more than 3 months. The use of tap water as a bladder irrigation has only been reported in 4 previous studies. 3 studies where the tap water was used as an irrigation solution or to dilute something, and another study where the tap water was used for prevention and treatment of UTI. And this one was a single center cross-sectional study, but was a not prospective study. So the proportion of UTI treated with antibiotics before and during the blood irrigation remained constant, suggesting that the observed reduction in antibiotic use was due to the decreased number of the UTI. So that's make a discussion that the final discussion is like this blood irrigation may have a better preventive effect rather than used as a treatment when symptoms are present. For example, extensive duration of the tap reschedule may have had a preventive effect against the UTI. And some of these patients, like I said, they were continually daily the blood irrigation as a preventive measure by themselves without, tapering the schedule that was recommended within the study. So what is the rationale behind the tap water? So what they think is that by washing out bacteria overgrowth and debris, this is we can prevent or treat. And also the hyposmolarity of the tap water, because for example, the E. coli in hyposmolar medium lose the viability and lysis of the microbes. So as always we say, the solution to pollution is dilution. So this one is probably the main rationale behind the tap water. When I looked for other blood irrigation in people, they describe saline, they describe chlorhexidine, they describe povidone, iodine, gentamicin, colistin, formalin, even diluted vinegar. So they use all of these studies that I found, they use most for prevention and less for treatment. If we compare the blood irrigation in dogs and cats, we can see that the study that we have out there, they use most for treatment than prevention. For example, there is an anecdotal installation of diluted chlorhexidine or a DTA via the cestotomy tube may decrease the incidence of bacterial UTI. Was a small study where it was a daily infusion of a DTA for 7 days, was well tolerated, and dogs had negative urine culture up to 180 days after the treatment. This was another case report where they instill amikacin for treatment of lower urinary tract infection caused by Pseudomonas aeruginosa in the dog. In this case report, the treatment of this multi-drug resistant Pseudomonas aeruginosa was successful after intravesical instillation of amikacin. So at the end, they say that the intravesical instillation of antimicrobial may be a treatment option for dogs with a lower urinary tract infection caused by multi-drug resistant bacteria. This is more recent case report where they use the ozonized saline solution in the treatment of Proteus, but for bacterial cystitis. This case report describes a paraplegic canine dog that has this recurrent bacterial cystitis that was caused by Proteus. And the bactericidal action was like of 2 different protocol irrigation with the ozonized saline solution. And the conclusion was that the repeated intravesical ozonized saline instillation within a 24-hour window shows superior bactericidal efficacy against the Proteus compared to the once daily protocol. This is another case report that they use ADTA for the treatment of a biofilm-associated recurrent E. coli cystitis in a dog. And it was a young female with recurrent UTI. There was a successful treatment using intravesical instillation of DTI as an adjuvant, in this case, to systemic antibacterial therapy. So regarding the urinary catheters, in our guideline, the International Society of Companion Animal of Infectious Disease say that the catheterization is associated with a risk of bacteriuria or bacteria cystitis. The presence of the urinary catheter, unfortunately, can predispose to infection, most from ascending migration of bacteria into the bladder. The bacteria can migrate inside within the catheter lumen or along the outer surface of the catheter. So the colonization of the urinary catheter or bladder can result in cystitis, subclinical bacteriuria, or extraurinary infection. So most of the time, they say that the causative bacteria commonly originate from the own enteric microbia. And during the catheterization is the most important risk factor for the development of infection. So also important to consider that the bladder can be a source of systemic infection. And the incidence of cystitis that followed by the urinary catheterization in dogs and cats is poorly characterized. Mostly because it is very difficult to differentiate between subclinical bacteriuria and cystitis. The routine cytological evaluation of urine is not recommended for detection of bacteriuria or bacteria cystitis. And the pyuria, hematuria, or cytological evidence of bacteria can occur in the absence of cystitis. Also, they don't recommend the infusion of biocides or antimicrobial into the bladder. There is no indication for routine prophylactic antimicrobial treatment follow the urinary catheter removal in an animal that has no evidence of cystitis. Bacteria cystitis should be suspected in catheterized animals that develop low urinary tract SAIM. Will be very difficult to in this patient that as in the Welling catheter, when for example when they are paralyzed, to see if they have clinical signs or not. So that's when they say that the infection should be suspected in all cases of fever of unknown region or bacteremia with an unknown focus. A sudden change in the character of the urine, so the odor, the gross appearance, should be something that they make us consider could be bacterial cystitis as developed, but doesn't mean that if we have all of these changes, this is not necessarily indicative of bacterial infection. But for sure, we have to further investigate it and not just treat for. So the bladder irrigation is a valuable technique for maintaining catheter patency, preventing clot retention, managing hematuria, and in certain cases for preventing and treating UTI. The proper indication, technique, and monitoring are critical to ensure patient safety and therapeutic success. So a simple procedure, when done correctly, can make a significant difference in patient outcome. Thank you, and if you have any question.
Well, thank you very much, Simona. I guess if there's no questions, we'll go ahead and sign off.
Okay.
All right. Have a great day. Thank you.
Thank you.